It's 1 p.m. and I think we should start. Professor Savarese asked me to open this afternoon session. My name is Mitja Lenschak, and in next 25 minutes we'll listen to artificial intelligence. For that, I do kindly ask Alicia Uhl from Netherlands to tell us how can artificial intelligence be instrumental for our heart failure patients.
Thank you so much for the wonderful introduction. Good afternoon, everyone. My name is Alicia Uhl. I'm very pleased to be here to talk a little bit more about AI. Mainly, I think I don't have to tell you that heart failure is becoming such a large problem right now in the world. We have older patients with many more comorbidities, and they all need to be treated, and they're getting more and more complex. And at the same time, all the data from these patients are collected in electronic health records. And we can use this data actually to analyze and to understand better why they're getting heart failure or what type of heart failure they have. But the amount of data that currently gets collected is getting so large that we need new methods to analyze. Ooh, this is actually quite high. to analyze these vast amounts of data. And I think this is where AI can help as a new methodology to help our patients with heart failure. So first off, I looked actually yesterday on PubMed what kind of literature is out there right now on AI or machine learning in combination with heart failure. If you just look at the title on abstracts right now, in 2025, there were 1,109 articles published right on AI. And if you look back 10 years ago, can you guess how many records there are? It's only 75 publications. So AI right now is booming business, and that can sometimes be scary, or it can be difficult to understand exactly how AI can help you as a cardiologist. So to put this a little bit more into context, AI is not a single tool or application that you use. I think you're very well aware that ChatGPT currently exists, and probably everyone uses it on a day-to-day basis, or if you open Google, you automatically get any results with AI. But actually AI in the clinical context, you think more about different types of methodology that can help you answer a clinical question. So I think it's really important to first always start with your clinical question and look at where the methodology can help you, and not the other way around and use AI as a fancy buzzword in your analyses. So the choice of model really depends on your clinical aim, and there's different types of AI that you can use. So you can use rule-based AI or machine learning or generative AI with large language models. But today we're going to be mainly focusing on machine learning because a lot of research in heart failure specifically has been done using machine learning as a methodology. There's two main types in machine learning. The first part is supervised machine learning. So what this actually means is that you have your raw data. Right now in this data we have cows, elephants, and camels, and they are labeled. So we know which one is a cow or an elephant or a camel. And using an algorithm, so using AI, we can determine, okay, indeed, this is an elephant and this is a camel and this is a cow. So if you translate that to a clinical practice, you can have a question, for example, will this patient be hospitalized within 1 year? Or does this echo suggest reduced ejection fraction? So it's really meant for these kinds of questions using risk prediction or decision support. On the other hand, we have unsupervised learning, in which we have the same raw data, but we do not tell the algorithm that an elephant is an elephant and that a camel is a camel and a cow is a cow. So the model itself, the algorithm itself, determines which patients belong together. So I think a very well-known example here is, are there any distinct subtypes in heart failure with preserved ejection fraction? There's been many publications right now on this topic. So this is very exploratory and looking more into classification of your data. So these are the main types that we have. And I wanted to show you a few examples today in different topics in heart failure. So if you look at more diagnosis, if you have an echocardiogram, what can be done with it? So this is a very recent publication looking at an automated analysis using AI of the echocardiogram and to see if you can predict worsening heart failure. And the really nice thing about this study that they did is actually compared their AI algorithm with a manual assessment. And they saw that actually the automated AI was slightly favorable compared to the manual measurements. But what it actually means is that this translates to, for example, time savings if not everything needs to be scored manually. And there was a better risk prediction. Another really interesting part about this study, what they did is that they were able to integrate their AI algorithm within the hardware. So that means it's actually you can implement it and you can use it in a way that fits within the clinical workflow. As I said before, the clustering or the classification in patients with heart failure and preserved ejection fraction has been booming business. I think over 40 papers have been published on the classification of patients with heart failure and preserved ejection fraction because this is such a difficult patient population, very heterogeneous, very diverse. And the hypothesis behind all of this was really, do we see a dilution in effects in these clinical trials that have all been neutral due to maybe different efficacy in different groups or clusters of patients? And this is where the whole idea came from in 2017 from Shah. One of the studies that I did myself in the Swedish Heart Failure Registry was clustering patients with HFpEF using latent class analysis, which is a methodology of unsupervised machine learning in which we use only 10 variables to identify 5 different clusters of patients. So you can see here, they're very diverse if you look at their profiles of their different clinical characteristics, and they're also very diverse in their outcomes, their risks for different outcomes. And I think the next step within clustering is really to see, do these clusters now also translate to differences in treatment responses? There have been some studies done in this based on clinical trial data that has been clustered, but we don't see any implementation right now in clinical practice just yet. If you look at prognosis and risk prediction, as I mentioned, supervised learning is a really big part of this. There's been a recent publication on medRxiv from Shishir Rao et al. And his colleagues in Oxford on T-risk in heart failure, which is a transformer-based risk assessment, so sort of a survival model. So think of it as like a Cox proportional hazard model, but then different. And what they did is actually they used data from multiple time points, from multiple visits, in order to predict 3-year mortality rates. And they compared this with the MAGIC EHR model. And what they saw is that between MAGIC EHR and the T-risk model, that the T-risk model outperformed the MAGIC model based on discrimination and calibration. So what they saw, they had a large reduced number of false positives and false negatives, and their the C statistic was 0.84, so a lot higher than what we see in the MAGIC EHR model, which was only 0.73. And then you maybe saw a little a note in the top which said AI for heart failure. So the Oxford team and our team in Amsterdam were all part of the same consortium, which is the AI for Heart Failure Consortium, in which we are working on building more of these trustworthy AI prediction tools that we can use actually in clinical practice. So what that could potentially look like in your own clinical practice is that you can have a recommendation from the tool. It can be filled in, already pre-filled in from your electronic health records, and it can give you a confidence score in how confident we are in giving any results for these patients if they have a risk of hospitalization or myocardial infarction or mortality, for example. And these are just mock-ups. The project is still on its way, so we hope in the next year or so to have an actual functional tool in the electronic health record system. But moving a bit, I talked a lot about electronic health records already, but I think AI is also possible in clinical trials. I think one of the new things that I've seen so far is using patient data in your electronic health records and putting this next to clinical trials that are available. So you can use, for example, natural language processing, which is one of those large language models, to actually match the patient data that you see. So it can be free text data, it can be already structured data, and you can match this with the available trial data and any characteristics that are needed to be included in these trials. And you can overlay those, and you can actually find trials for patients to participate in. And if you integrate that in your hospital, in your electronic health record system, you have a very fast way of including new patients for your trials. So you can have faster and more effective trials that are hopefully a little bit less expensive. Another new thing that we see in the clinical trial field is also the use of wearable data, of course. So wearable-derived endpoints could really be beneficial for the patients with heart failure, especially for those patient-reported outcomes that are important for them, like the 6-minute walking test or the KCCQ scores that are sometimes used. And there have been some early adopter trials that show a correlation between the daily use of these wearable devices and the levels of these 6-minute walking tests and KCCQ scores. And this is a recent review that looked at the different types of wearables, which generate a lot of data, which can then be analyzed with AI and machine learning. So this sounds all very positive, and I hope that you've seen that I've also tried to include as much recent data as possible. So a lot of this data is actually just from 2025 or published last week. And this is such a highly evolving field with loads of new studies being done every single day. But that just generates a lot of new models, but do actually see these models coming back in clinical practice. So there's a part about implementation and usability that I wanted to talk about, because we want to go from this black box to opening the black box and understanding what these AI models can do for our heart failure patients. So I wanted to talk to you a little bit about the different challenges that I see within the implementation of AI models. I think the first question is, where is the big data? Because you need large data sources in order to train your models, to reduce bias, to make sure that the models that you're generating can be applicable to all the patients that you're seeing. And a large part of it that hampers this kind of stuff is the interoperability of the electronic health records. So you have data in different parts in electronic health records, need to link this between GPs and hospitals, or the data quality can be a little bit lower because patients are seen in daily clinical practice and maybe not all information is filled in all the time. A second part I think is very important is the explainability and the trust of the clinician. And I think it's very good that clinicians are showing some question marks about the AI models and thinking, okay, is this indeed good enough? Can I show this to my patient? Because if you are with a patient in your clinical practice and you get a result from an AI, can you trust that result? Can you show indeed, okay, this is what it's based on? Can you make the AI explainable? I think it's also very good that there's a lot of regulatory and ethical considerations with AI. There is the European AI Act that's indicating to be wary of all the different AI models that are now being developed and to be potentially used as medical devices in the field. Of course, this does hamper the translation from science to actual practice, but I think it's good to consider all these different regulatory and ethical parts. And lastly, I mentioned this already before, the integration into clinical workflows, because if your AI doesn't help you in your clinical practice, then where would you be using it? So I think it's very important for data scientists to work together with clinicians to answer the right questions that clinicians are struggling with, and which AI can be a method to help you, and not just a product because it's a buzzword right now and we can use AI. So a few parts I wanted to talk to you about is within AI for heart failure, we've developed the Future AI Guidelines. So these stand for Fair, Universal, Traceable, Usable, Robust, and Explainable AI, just to make sure that we need to think about what we are doing with our AI models and how to use them in the clinical practice. And one of the things that we are developing is an AI monitoring tool in which we have a quality control of how well the models are performing in the clinical practice, and that we always make sure that there's a human in the loop, because you cannot just let AI make the decisions on its own. There's always needs to be some sort of check with a human, and we can create this monitoring platform. So a few take-home messages after all this information that you've just heard about AI. We see that in AI, a lot of the models are performing just as well or sometimes even better than conventional models. So they can be really useful in answering those complex clinical questions that we have in heart failure. They can provide support in clinical decision-making, but I don't suggest that we should replace it. It's very important to realize that AI models reflect the data that they are made of. It's a data-driven approach. So it can introduce bias if you're not careful and make sure that your models are externally validated on other data sources, for example. And also important to increase your interpretability and the clinical usability. I think everyone's sometimes falling over how complex AI can be in the technical aspects, but I think it's even more important to focus on integration into clinical workflows to make sure that the complexity can be handled in the models, but we need to make sure that we can actually integrate them to make them useful. Thank you very much. That's all I wanted to talk to you about.
Thanks for this wonderful overview and also highlighting that project AI for heart failure. Any questions? We have a couple of minutes. Maybe I'll start. With artificial intelligence, do you think that we are maybe skipping what we should do first? Because at least I'm not aware of any study or publication that would help about better epidemiology information. Because the health records, physicians are awful in writing discharge letters. Everybody has its own style, and this is not structured. You cannot retrieve the information easily.
Yeah.
What about NLP to do that? Because that would then be, and for heart failure, 1/3 is hospitalized at cardiology wards, the rest is somewhere, and we don't know how they are treated, and every single registry, with the exception of very few, is biased. So was there any effort to do something in that direction?
I think AI is mainly used for risk prediction and exploratory research in the phenotyping field, not so much in the epidemiology field. I think what you're saying about the discharge letters, I think is a really, really good idea. I know that some people in my team are working on these kinds of large language models and seeing if we can extract any information from random text and make this more structured. So we are working, for example, in our own electronic health record system, we are working on this. So any information that's filled in free text fields, we're trying to make them also structured. Just to make it easier indeed to understand, okay, does this patient indeed have diabetes? What happened before? You can even use speech. So if it's spoken, it can be translated back to text and it can be inputted somewhere. I think there's a lot of different ways in which we can use these kinds of models for the epidemiology, but we should be wary as well of the companies that are producing these kinds of algorithms, for example, because you need to make sure that the patients are still, their data is still private. So I think this is probably the largest roadblock. I think what you're saying is possible, but just ethically, we need to consider how to go broad with this.
You mentioned AI for heart failure. Will there be deliverables that will be publicly available because this is the publicly funded project?
Yes, for sure. So we are creating a toolbox in which we are creating a common data model. So that means that if you have data from different hospitals, that they are operationalized in the same way, so that we know that when we indicate that a patient has diabetes in one hospital, that we also saying we're using the same clinical codes to identify patients in the other hospital. And we can use that to impute that into a federated learning platform, which we're also building and will also be publicly available, in which you can train AI models, so mainly risk prediction models because it's with structured data. But we can use this platform as a privacy-preserving method to analyze data across Europe, so reducing any biases that you might have if you train only on a single data set. And train privacy preserving across different hospitals, and you can update your model every single time. You can have local models that are specifically tailored to a local hospitals. You can have a single model for all European centers. So we're working together with 8 hospitals in AI for heart failure. We had an open call and we included 3 more sites that will also be in the whole loop of this common data model. And yeah, once we're done with the project, we're open to any other hospitals that want to be included in this, so we can train large AI models across Europe.
How do you see the future with artificial intelligence? Will there be the need for medical school and doctors?
Yes, for sure. No, I definitely think so. I briefly mentioned it during my presentation. I think it's really important for us to collaborate with each other. So I'm an epidemiologist. I dabble in data science because I found it interesting. So now I've rolled into the AI field because of that. But I think if I talk to true data scientists, they have no idea what anything means. They don't know. They call everything features, feature selection this, and we are labeled, and they don't talk about it as a patient, which I think is crucial if we want to answer questions that are pivotal for both clinicians and patients. So I think what I always try to do in my own research is I try to collaborate with different people with different disciplines. So clinicians, epidemiologists, and data scientists should all collaborate together to create these models and to help also to teach the clinicians in school, indeed, to understand how you can use them. Right now, what we see in medical school is, for us, so if I teach, it's always, you cannot use AI, you cannot use AI, you cannot use AI, but you can't go around it. AI is everywhere around us. So we need to think about how can we safely introduce this to our new clinicians, a new generation of clinicians.
Any questions? If not, then I do thank you for the great conversation. And please note that artificial intelligence is the spotlight of the next year's European Society of Cardiology Congress. So submit abstracts with artificial intelligence or on artificial intelligence. Now we'll give floor to Dr. Six.
So welcome to the next session, Recognizing Advanced Heart Failure. We have an interesting hour ahead of us with some key experts in the field, Dr. Fredrika Guidetti, Professor Willifrid Müllens, and Professor Benedikt Schage. I am chairing this session. My name is Mikael Melin, Karolinska Institutet Södersjukhuset, and I'm chairing this together with Professor Ovidio Consell and Associate Professor Oskar Braun. And we also have a discussant, Professor Lars Lund. So I'm leaving it to you, Oskar, to introduce our first speaker.
Yes, so I'm very happy to introduce the first speaker, Fredrika Guidetti, who is an advanced heart failure specialist in Bern, but also a PhD student here for Gianluigi at Karolinska. So and you're going to talk about how to manage drugs and medical therapy in advanced heart failure.
Good afternoon, everyone. Thank you for the kind introduction. I'm really delighted to start this session about advanced heart failure. I have no disclosures. When we talk about advanced heart failure, we refer to severe symptomatic patients despite optimal medical and device therapy who should be evaluated for heart transplantation and HealthVet, and if not suitable, refer to palliative care. Among advanced heart failure patients, we can generally encounter 2 different clinical scenarios. One is the chronic advanced heart failure scenario, consisting of ambulatory patients reporting severe progressive symptoms despite optimal medical and device therapies. And the other is the acute and chronic and acute de novo advanced heart failure scenario, consisting of patients presenting with acute heart failure, cardiogenic shock, electrical storm that we cannot stabilize using inotropes and temporary MCS, and therefore required urgent evaluation for advanced heart failure therapies. Although most patients with advanced heart failure have a reduced ejection fraction, the definition of advanced heart failure includes patients across the entire ejection fraction spectrum. However, due to time constraints, my presentation today will focus on chronic advanced heart failure patients with reduced ejection fraction. These well-known pictures represent a progressive nature of heart failure. Despite early initiation and rapid application of GDMT and use of devices that substantially reduce the risk associated with heart failure, as we well know, a residual risk remains, and as a consequence of that, some patients experience worsening heart failure, defined, as we heard yesterday, as a deterioration of sign and symptom requiring escalation of diuretic therapy, and 10 to 50% may even proceed to the advanced heart failure stage, which is characterized, according to the HFA definition, by the contemporary presence of these four severity criteria: severe symptoms, severe cardiac dysfunction, more than one unplanned visit, hospitalization within 12 months, together with severe impaired functional capacity despite optimal medical therapy. However, we also have additional important red flags that should be recognized to timely identify and refer to advanced heart failure patients that are well summarized in the High Need Help acronym. Even though worsening heart failure and advanced heart failure have been defined separately, recent studies have demonstrated that they are associated with similar risk of adverse events. It absolutely mirrors something that I face in my clinical practice, and for this reason, I'm gonna mention both in my presentation today. Go to the topic, how we should treat patients with worsening heart failure. Here I reported recommendation from the statement of the American Society of Cardiology. When we face patients with worsening heart failure, we first have to treat congestion using diuretics, however, starting, adding, increasing as soon as possible GDMT, and if patients do not already receive it, preferring probably SGLT2 inhibitors, since they demonstrated early benefit in terms of outcome and they facilitate decongestion. Physicians should also start or increase the dosage as soon as possible of the remaining 3 pillars. And doing that, they have to prioritize initiation use of all these 4 medications, at least at low doses, rather than up-titrate one drug at a time. And it was demonstrated beneficial in the STRONG-HF. It's important to closely follow this patient and try to achieve the maximally tolerated doses as soon as possible, not later than 4 to 6 weeks. However, as we heard yesterday, we do not only have the 4 pillars. After the publication of the Victoria trial, vericiguat got a 2B weaker recommendation in this subgroup of patients with recent worsening heart failure events. What still remain unclear, and we mentioned that yesterday, is the appropriate time point to start the vericiguat respect to the 4 pillars. The recommendation in this statement was to to go for an upfront early initiation simultaneously with quadruple therapy in patients with contraindication for one of the 4 pillars. However, this is also what I do in my clinical practice. If patient presents with a good GDMT tolerance, first up-treated them and reserved vericiguat for a second worsening heart failure event. Moving to the advanced heart failure setting, even though these patients are at higher risk of event, if we look at real-world data, they are less likely to receive GDMT even in the absence of contraindication. These are data from the HELP-HF, an observational retrospective study conducted in Italy, enrolling patients with at least one INAID HELP criterion. As you can appreciate here, 82% received beta blocker, however, only 54% RAS and HARNI, and even a lower proportion, 44%, received MRAs. When author investigated reason for non-use and for underdosing, marked in light green, in the majority of cases that was due to unknown reason, highlighting the existence of a clinical inertia trait in these patients. Other very common reasons were hypertension, hyperkalemia, and worsening renal function, well-known adverse events that can occur. However, we cannot only underestimate the role of skepticism regarding effectiveness of GDMT in this setting. What it happens that often physicians argue that except for the LIFE trial, that was a negative trial, no studies have been properly conducted to investigate efficacy of GDMT in this setting. Here I've summarized for you the results of these HFrEF landmark trials with their inclusion criteria and results, trying to convince you that that is properly not true. The first studies investigated ACE inhibitor, beta blockers, and MRAs, and they demonstrated that these drugs are effective in severe symptomatic patients, given that they only enrolled patients near class 3 to 4, and they were all positive trials. When we move, however, to more recent studies like the PARADIGM-HF and the DAPA-HF, as you appreciate here, the proportion of severe symptomatic patients enrolled was significantly lower, not greater than 1%. And when an interaction term was introduced between near class and outcome, P of interaction was significant, and it seems that this drug was less effective in more severe symptomatic patients. To better investigate if dapagliflozin is effective in patients with severe heart failure, this pooled post-hoc analysis have been conducted, considering patients from DAPA-HF and DELIVER. The author defined severe heart failure as reported here, and they investigated if dapagliflozin was effective in severe heart failure versus non-severe heart failure patients. Here the study results, as you can appreciate from the hazard ratio, dapagliflozin was effective in both groups, and by a non-significant P of interaction, it was effective regardless of the severe heart failure status. As I mentioned before, the PARADIGM-HF enrolled just 1% patient near class 4. Accordingly, to better investigate if sacubitril/valsartan is effective in patients with advanced heart failure, this additional trial has been performed after the LIFE trial, comparing sacubitril/valsartan to valsartan in patients with advanced heart failure. Importantly, the study excluded patients with severe CKD, symptomatic hypertension, and waiting for heart transplantation or HLVET. According to the study protocol, after screening, all patients underwent an open-label run-in phase, receiving 50 milligrams twice daily sacubitril/valsartan, and importantly, only those who tolerated it proceeded to the randomization. Here the study results, unfortunately, was a negative trial. First, 80% did not pass the run-in phase due to drug intolerance. The study was negative for the primary outcome, no differences in NT-proBNP reduction within 6 months, and no differences in the secondary and tertiary outcome that were hard outcome, they alive out of the hospital and cardiovascular death. However, the study was not powered for that. In terms of safety, however, except for an higher rate of hyperkalemia in the sacubitril/valsartan groups, no differences were found. Very important is to mention that the open label running phase gave us the unique opportunity to investigate reason for intolerance and withdrawal of sacubitril/valsartan. As I mentioned before, 80% failed the running phase, and this was mainly due to symptomatic hypertension followed by renal dysfunction in a very small proportion due to hyperkalemia. Actually, what the study showed is something that we frequently face in our clinical practice. It's more difficult to start and uptitrate GDMT in the severe symptomatic patients. However, it's not impossible, and there are some strategies that can help improve tolerability. For sure, initiate at low dose and proceed with a gradual slow uptitration, slower than what we generally do. I prefer personally start with SGLT2 inhibitors since they are well tolerated and they reduce the risk of hyperkalemia due to MRAs and HARNI. I never start a beta blocker as long as patients have a sign of decompensation. And if patient presented with bradycardia, I prefer start beta blocker symptomatic and severe. I prefer start beta blocker after CRT and ICD implantation, anticipating it, however, especially if patient presents with LBB. It is important to remember generally, but even more in this patient, that a moderate eGFR decline is not associated with worse outcome when due to GDMT implementation, so no reason to stop GDMT just because of that. And we also have to remember to consider potassium binders in patient experiencing hyperkalemia. What is even more important is to perform close follow-up of this patient, spending time educating patient to manage adverse events like dizziness, and if patient report it, it's important to reevaluate the volumen status and if possible reduce diuretics to avoid over-diuresis. That is often one of the major obstacles to uptitrate GDMT in these patients. When we have put all your effort to optimize GDMT, implant devices and treat comorbidities, we have, however, to closely reassess our patients, and if they present worsening heart failure or you need to reduce GDMT, you have to refer this patient as soon as possible to advanced heart failure centers to avoid missing the gold window to receive advanced heart failure therapies. Looking ahead for new pharmacological treatment with the potential to improve outcome in these patients, especially if we consider that in the next year we expect an increasing proportion of advanced heart failure patients not suitable to advanced heart failure therapies due to aging of heart failure population, new drugs have been investigated addressing different target mechanisms. In this context, the GALACTIC trial investigating omecamtiv mecarbil and oral inotropes demonstrated for the first time an 8% moderate reduction in the risk of primary outcome that was considered, however, not enough for the approval of the drug. After the main publication, however, very interesting post-hoc analysis came. Here I reported one that investigated efficacy of omecamtiv mecarbil in patients with severe heart failure versus non-severe heart failure. As you can appreciate here, while in the severe heart failure groups, the drug showed a 20% reduction in the risk of primary outcome, no benefits have been found in the non-severe heart failure groups. The results of this post-hoc analysis, together with other that show greater efficacy of omecamtiv mecarbil in patients with hypertension compared to normotensive and with greater ejection fraction reduction, led to the hypothesis that probably if the trial have been conducted in more severe symptomatic patients, it had showed probably a greater efficacy. That is something that for me makes sense if we consider that we are giving inotropes. For this reason, the COMET-HF trial comparing omecamtiv mecarbil to placebo have been started, targeting severe heart failure patients. It's now ongoing and we are looking for the results. Highlighting the interest in investigating new drugs in a subgroup of more symptomatic patients we already heard yesterday, recently the DIGIT-HF has been published showing that the low plasmatic concentration of digitoxin had led to a significant 80% reduction in the risk of primary outcome. I would like to conclude my presentation with these take-home messages. In all patients with worsening heart failure and advanced heart failure, every effort should be made to uptreat AGDMT as it confers a proven prognostic benefit and remain the foundation of treatment. However, heart transplantation and LVAD remain the treatment of choice in patients with advanced heart failure despite optimal medical therapy. Accordingly, it's important to perform close follow-up to facilitate GDNT uptreatation initially, but also to timely identify patients who deteriorate despite optimal medical therapy, who are not able to tolerate uptreatation, to timely refer this patient to advanced heart failure therapists. Thank you.
Thank you, Federica, for a very interesting talk. I will introduce the next speaker, which is Wilfried Müllens, professor in Belgium. He will talk about diuretic resistance in advanced heart failure.
Good afternoon, everybody. Again, I'm sorry I couldn't be with you. My flight was canceled yesterday evening. So diuretic resistance. So first of all, you have to recognize that the kidney is a very long tubule, and the objective of the kidney is to get rid of toxic substances, but the objective of the kidney is not to get rid of sodium and water. So there is a lot of sodium and water retention mechanisms in the kidney, which are increased if you have heart failure, if you have hypertension, if you have cardiovascular disease. So there's an increased sodium and water reabsorption in the kidney, especially in the proximal parts of the kidney. So bear in mind that when you think about diuretics. There is very old work from John Cleland showing that patients with heart failure, especially with advanced heart failure, have significantly more sodium retention than they have water retention. You see almost more than double the amount of sodium is retained compared to water. So water is following passively, and the water retention is mostly extracellularly stored. If you believe this, and I do believe John's data, then the aim of decongestion should be natriuresis more than diuresis, while providing potassium chloride supplementation, because your kidneys lose a lot of potassium while they're retaining sodium. If you think about how diuretics work by increasing diuresis, and therefore the urinary sodium concentration is not so high. If you don't use diuretics and you eat a lot of sodium, the sodium levels in your urine can be up to 280 millimoles per liter. Bear in mind that your serum sodium levels are 140. If you give diuretics, your urinary sodium levels will always be lower than your serum sodium levels. Therefore, we're aiming for urinary sodium levels above 70, above 90 millimoles per liter, which is always lower than what your serum sodium levels are. In other words, when you give diuretic therapy, you're actually creating a hypotonic urine, and if you don't give access to water, people cannot lose their sodium. So this is a contrast to what most people are telling you, but it's probably okay that you let people with advanced heart failure drink, because otherwise they can't lose their sodium. Now, diuretic resistance, what is that? That's basically not having a normal diuretic response. If you give diuretics, that is omnipresent. Every patient with heart failure has diuretic resistance just because of the phenomenon that the kidneys have an increased sodium reabsorption when they are dealt with heart failure. We're trying to overcome the poor utilization of loop diuretics by writing consensus documents a couple of years ago, which has now been incorporated in our ESC HF guidelines. So let me guide you to the different targets that you can actually use, the different diuretic targets that the nephron actually has. And I think there are 6 decongestive rules. It's not so complicated. First of all, it's door to diuretic time. There is no time to waste when you're faced with a patient with advanced heart failure who is decompensated. Just give the diuretic as soon as you see him. Because if you don't do it, the person after you will also not do it, and then there is no decongestion. How much do you give? You give enough. You cannot give too much. So we advocate in the guidelines to give twice the home dose at least. So if your patient was on 40 milligrams, you give 80 milligrams IV bolus. You need to give a bolus in order for the drug to actually act. We also advocate using early combination with a second-line agent. First of all, the pharmacokinetics of diuretics. Diuretics are protein-bound drugs. They need to be actively secreted in the nephron, so you need to give high enough dosages. You need to give them intravenously because if you give them orally, they will not be absorbed in your gut. Secondly, they work for 6 to 8 hours. This means that you have to give them at least 2 times, but preferably 3 times per day, especially during the first days of decongestive therapy, in order to actually excrete sodium and water. The third important point with regards to pharmacokinetics is that if you give only loop diuretics, that your urine will become more hypotonic day by day. This means that you cannot lose sodium anymore, but you're only losing water when you give only loop diuretics as a monotherapy. That is the reason why we advocate giving a combination therapy. What can you add? Well, you can add hydrochlorothiazide, which has been tested in the chlorotic trial, double-blind trial in Spain, where you see that the primary endpoint of weight loss was a little bit more when they were adding hydrochlorothiazide. First problem when you add hydrochlorothiazide, even though in a very high dose in the low GFR patients, that there is no weight loss anymore. As you can see here, in the patients who received the highest dose of hydrochlorothiazide with the lowest GFR, there was absolutely no benefit with regards to weight loss. Thiazides are also linked to an increased mortality if you give them long-term, probably because of more prevalence of hypokalemia. What about a high-dose spironolactone? This has been tested in the ATHENA trial. Usual care was 25 milligrams. The SPIRO arm was 100 milligrams. And as you could see, there was no additional benefit of increasing the dose of spironolactone during decongestion. This does not mean you should not give it. It means that you should give spironolactone, but if you increase the dose, you're not going to get patients much more drier. What about SGLT2? These drugs are absolutely mandatory for everybody with heart failure, also in acute heart failure. And if you give them acutely, you increase diuresis more than natriuresis. And let's face it, in the future, everybody should be on an SGLT2 inhibitor. So when the patient comes in, there's not much to gain by increasing the dose. So the only drug we're left with is acetazolamide. It's the oldest diuretic agent available. It blocks carbon anhydrase in the proximal parts of the kidney, and therefore it increases natriuresis. When you give acetazolamide on top of loop diuretics, you double the amount of sodium excretion. So you go from 1% to almost 3%, which is a significant rise in natriuresis. We tested this prospectively double-blind multi-center in the ADVOR trial, and the trial's primary endpoint was, is your patient dry? Drying being defined as having no edema, no pleural effusion, and no ascites. But we saw that after 3 days, which was the primary endpoint, that the combination therapy of acetazolamide once daily on top of loop diuretics compared to loop diuretics monotherapy, that you do 46% higher likelihood that your patient would be dry. Now, many of you don't give acetazolamide for reasons that I don't really understand, but still, if you don't give it and you look at the numbers at discharge of decongestion, you see that the patients who received upfront therapy with acetazolamide had significantly higher likelihoods of being dry at the moment of discharge. Why is this? Well, this is because you prevent loop diuretic resistance from occurring if you give acetazolamide on top of loop diuretics. Loop diuretics work at the loop of Henle, so they work pretty distal in the nephron, while acetazolamide works proximal. Therefore, you'll boost your loop diuretic effectiveness and you actually prevent loop diuretic resistance from occurring. Acetazolamide also seems to work on all GFR reagents, in contrast to what we have seen in the chlorotic trial with thiazides. What is the third rule? Well, the third rule is that you have to evaluate the diuretic effects. How do you do that? Well, you either measure urinary volume, which should be at least 100 to 150 cc's per hour, or you measure the urinary sodium concentration. Urinary sodium concentration is very important, shown here in the sub-analysis of the ROSE trial, where they saw that only patients who had a negative sodium balance, meaning more sodium coming out than going in, had an improved prognosis. Patients with fluid loss but without a negative sodium balance do not have a good prognosis. How do you change the therapy? Well, you change the therapy according to what you're measuring. So if your urinary volume is less than 150 cc's per hour, or your urinary sodium level is less than 70 millimoles per liter, you have to increase the dose of the loop diuretics immediately. You shouldn't be waiting until the next day, but please give another bolus of IV loop diuretics, double the dose of what you were giving previously. Why is this important, or has this shown to be important? Absolutely. There was an ENACT study, which was an international multi-center study. PUSH-AF was a single-center study run in Groningen. Both trials showed that there had a tremendous increase in natriuresis when the physicians were acting upon what they were measuring compared to standard of care. Now, many of you say this is cumbersome. I cannot measure urinary sodium levels because then I have to send urine to the lab. I have to wait for the results. But there are smart sensors now available, point-of-care sensors that can be bought, that can give you the result of urinary sodium within a second. And these sensors are actually being used by our nurses now to titrate diuretic therapy in the emergency room and in our intensive care units. Fifth rule is that you only stop decongestion once your patient is dry, while you're optimizing guideline-directed medical therapy. We do know that there is an underappreciated risk linked to residual congestion, both in ambulatory and in hospitalized patients. And Alex Mebaz has shown in a strong HF that if you improve your GDMT uptake, that you improve prognosis. The sixth rule is what to monitor. First of all, you have to monitor potassium levels. Why? Because many patients are having hypokalemia, especially if you use a thiazide. In chlorodic, the incidence of hypokalemia defined by potassium levels below 3 was 50% in the hydrochlorothiazide arm. And this is, of course, linked to increased VTs. Low potassium levels are also causing diuretic resistance. Many people don't know this, but if you have a low potassium level, you increase your aldosterone levels, therefore you increase the incorporation of ENaC channels, which promote distal sodium reabsorption. So just give spironolactone, please, and give some potassium chloride supplementation while you're actually giving diuretic therapy. The other thing to monitor is GFR, diuresis, and hemodynamics, because if you do that, you can phenotype patients. For example, you have a patient who is still wet after the first day of decongestive therapy. He does not have worsening renal function. He has a good diuretic response and he's hemodynamically stable. You can call this a responder and you continue the same dose of loop diuretics. In contrast, if you're faced with a patient with worsening renal function, so meaning the serum creatinine goes up or the GFR goes down, but who still has a good diuretic response, this is pseudo-worsening renal function and you shouldn't care about this. This is not harmful, you just continue the same dose of diuretics. If you, however, have a patient with a poor diuretic response, you have to act upon it and you have to change the dose of loop diuretics. If you're faced with a patient who is hemodynamically unstable, meaning a really low blood pressure, really poor perfusion, those are the patients that need further care, maybe via mechanical circulatory support. So I think I'm going to conclude here. There are 6 decongestive rules: door to diuretic time, appropriate dosing and use early combination, do an early evaluation of the diuretic or natriuretic effect, use a natriuresis guided approach, only stop when your patient is dry, monitor potassium, GFR, diuresis, and hemodynamics. Thank you for your attention.
So it's my pleasure to introduce Benedikt Schrage. talking about candidates for left ventricular assist device, heart transplant, and palliative care. Benedikt.
Thank you so much for the kind introductions. Okay, yeah, there it is. Perfect. So it's always a pleasure to come back to Stockholm and give a presentation here, since I also did my PhD here a couple of years ago with Gianluigi, so it's always a bit like a coming back. So my role today is to speak about selecting the right patient for the advanced heart failure therapies we spoke about in the first presentation, transplant, LVAD, and even palliative care. And I think this is a really fascinating topic which probably can fill a whole evening. So these are my disclosures. And it's so important because when talking about advanced heart failure, we really are talking about patients who have a very burdensome outlook on their prognosis. We are talking about 5-year survival rates of 40 to 35%, or a median survival of 2 years. So these are really patients facing a bad prognosis. And we try to implement whatever treatment we have to stabilize their course, to improve not only their mortality rate, but also their quality of life, and to give them a better chance. So basically, when talking about therapies for advanced heart failure, we're talking about the last line of therapy in heart failure treatment, which is also visualized by the fact that in this nice scheme of treatments we get presented from the heart failure guidelines, it's actually not the quadruple therapy, which are the 4 pillars, but the pillars on the bottom are heart transplant and durable LVADs. So basically, that's what we're going for in these patients, because we do have the gold standard treatment, which is the heart replacement therapy, which is the heart transplant, which has a 1C recommendation. We also now have the widely more available therapy of durable LVADs, now in the 3rd generation, which has a 2A or 2B recommendation, either as a bridge to transplant or as a destination therapy in itself. And I think this represents a fascinating portfolio which we have and can offer to select patients. So I think this is a good question. What is the right candidate for heart replacement therapy? What is a good candidate for advanced heart failure treatment? And that's something we need to discuss and consider, because it is quite complex to identify the right patient. Because it is not only about the patient, him or herself, it's also about surrounding factors. So basically, we try to answer not one question, what is the right patient, but we try to answer 3 questions. Is the heart of the patient sick enough? Is the rest of the body well enough? And can the patient adapt to the lifestyle after transplantation or after durable LVAD? Because we really, with these therapies, interfere with the whole multi-organ system of the body. We interfere with the patient's lifestyle and what's coming after that. That's not just one pill we add or a therapy we modify, but we basically completely change the life outlook of a patient. And answering this question is quite complex and it demands time. So the screen tells me I have 11 minutes left, and I think we cannot really answer all these topics and address all this in such a limited time. And from our clinical practice, we do know that discussing this with our patient takes a lot of time. This is not a one-sitting thing where you say, okay, you are a potential candidate for heart transplantation. You go through a checklist and then you decide you do this or not. So basically what you do, either talking about transplant or LVADs, you have multiple sessions, you present the therapy, present the consequences, the patient thinks about it, you evaluate. It's a complex thing. So I think the far more important question is not what is the right patient, but what is the right time to refer a patient for this process. And one could rightfully say, if we look at this graph, which is, I think, widely known and nicely depicts the typical course of a heart failure patient, that we want to target the bottom part. We basically want to wait until the patient is so sick that we insert, for example, a heart transplantation or an LVAD, and then improve the outlook and outcome of a patient. However, irrespective of talking about durable LVADs or heart transplant, we need to keep in mind that how we send the patient into such a procedure largely determines how the patient comes out of the procedure. And it's depicted by this graph, which basically shows the intermax status of patients going to durable LVAD, but it works the same for patients going to transplant. And basically the message here is the right candidate for durable LVAD or heart transplant is optimally not in a multi-organ failure, is not severely malnourished and cachectic, because all these are determinants of the outcome after the transplant. The idea is to restore quality of life and longevity for the patient. So the pre-therapy status should be well enough to allow for this. So we do not want to be too late. We do not want to wait for too long to refer the patient. And then we could go to the opposite spectrum and say, okay, why not talk about this very early with the patient? And I think that's also not good, because when we are too early, we might confront the patient with a therapy which is too far away for him or her, because although heart transplant is considered the gold standard and durable LVAD a close second to that for patients with advanced heart failure, these are still therapies which really impact one's life. There are inherent complications to those treatments for heart transplant. That would be the fear of a rejection, the infection which comes from the immunosuppression, the risk of cancer or lymphoma, which also comes at the consequence of the immunosuppression, and so on. And for the LVAD, it would be stroke, embolism, thrombosis, bleeding. So all these are things which patients then have to face later on. So if we initiate those treatments too early or present those treatments too early, we might create a certain fear in the patient or waste a good opportunity for a good treatment. So those treatments come with drawbacks, and they are not early stage treatments for our patients. So we should first go for native heart recovery. We should build on the pillars of GDMT we have just learned about. We should exhaust the options of valve treatment, device treatment, and maybe CRT if feasible. But we should keep in mind that we don't want to be too early. We do not want to be too late, and we already heard the term the golden window of referral. So that's basically what we're aiming for. As so often in life, it's the golden middle, because this gives us still time to go through this process with the patients, to do the exhausting procedure of evaluating if we need an LVAD as a destination therapy or as an LVAD as a bridge to transplant. If we can go, depending on where you are geographically, you have different rules or restrictions for the transplant programs, and all this needs time to be considered. And I think starting this process early enough allows you to have this time with the patients, the families, to go through this process in a good way. So what are typical triggers for referral? And I just brought a case because I think this nicely illustrates this. And when talking about transplant or LVAD, you might be inclined to think, okay, we look for specific characteristics. We want to see a specific echo, like this one. That's a relatively young female patient after myocarditis. So you have a large left ventricle, so the LVAD inflow cannula rightly fits into there and might be a good candidate for that. But I think the prime triggers are not that, because we are not yet at the stage of therapy, and there are so many options to deal with that. There are so many combinations and add-on therapies. I think the triggers should not really be focused on the therapy thereafter, but the triggers should be focusing on identifying patients who are failing on GDMT, who are failing on the baseline therapy. So I think the most important trigger to refer a patient to be evaluated for the advanced heart failure treatment is symptomatic despite optimal medical therapy. And especially those patients, we already had that in the first talk, in whom you have to de-escalate an existing treatment because of an inability to tolerate it. So that's a major red flag and should prompt the referral to a center where LVAD and transplant is evaluated. Also, recurrent hospitalization, unplanned hospitalization is a major trigger for referrals. Especially, you can basically cross a line that one hospitalization might be okay, but after that you should think about referring a patient. And I think the most important thing here is that you do not miss that the patient is quickly deteriorating and then that you lose the time to go through the evaluation process. And the third major red flag which should trigger a referral is the worsening of other organ functions. I think the easiest or well-known is worsening renal function, because we do not really help the patient if we let heart failure progress to such a state that all the other organs are also severely damaged, and we may achieve a better functional outcome for the heart, but still have the patient dialysis. Obviously, these are combinations, and this is done in practice in real life, but we should try to be faster and not wait for the other organs to fail. And I think what this gives us, if we use these triggers, then we really can use the whole portfolio of existing therapies to improve our patients. And this is important because this allows us to pick from the huge toolbox we have and apply or tailor the treatment to the patient, his or her needs. And we might also judge that it is not yet the time to do so, and we might opt for very active, watchful waiting with one of the monitoring devices. There are there's a huge portfolio of things we can do, but we need to see the patient early enough to do so and to apply these. Also, there are sometimes comorbidity we can alter, such as obesity or other risk factors. And similar as shown before, if we optimize those before transplant, before LVAD, we then improve the outcome of the patient after that. So I think that highlights why it is so important to send those patients early enough to have enough time to really discuss those options and do a treatment plan for a patient. And also, and that's in the title of this talk, and I think that's the third pillar here, it's also totally okay to refer a patient and then together decide that transplant or LVAD is not a good option, that we have exhausted the existing therapies, that we have a path therapeutically which has a certain end, and then together determine that when things happen, we go for palliative care to improve the quality of life. And I think the data on that is very convincing. We should not discuss the validity of palliative care in these patients anymore. This is a disease which can be the last disease a patient has. And if we have exhausted our option, we should recognize that and be open and honest about that, because then the patient and his or her family has time to adapt to that. And that's also something which is only allowed if this is done timely, because if we see those patients in the 6th hospitalization within a year on the ICU on a ventilator, it might be too late to really initiate a good process to talk about this. So that's why the timing is, I think, the single most important thing. And I thought about the listing maybe the triggers for the referral here, but I think the main message I want to give to you with this talk is that we need to see the patients with advanced heart failure early enough to have a discussion with them and their families about what we can do technically and what we should do and what they agree to and how we both shape the treatment plan for them going forward. Thank you so much. I'm looking forward for the discussion.
Thank you, Benedikt, a great presentation. Before the panel discussion, we have actually a fourth chair that we want to introduce, participating from India, Dr. Yashankar.
Hello,
So
good evening. Good evening, this is Dr. Jayashankar from India.
So, Oscar, do you want to start? Do you have any questions, Dr. Jayashankar?
Yeah, I was just wondering if, wonderful talk, Dr. Mullins. Just a word about what all the treatment options for diuretic resistance. You mentioned acetazolamide as one, and dose escalation of diuretic as well. So what treatment options do clinicians have?
Well, I think diuretic resistance, like I tried to explain, is basically something that every heart failure patient actually is encountering. And by using our approach, what we also advocate in the guidelines, by using high enough dosages of loop diuretics, a frequent monitoring of the diuretic and natriuretic response, then changing the dose according to that, doing a combination therapy with acetazolamide or thiazide early on actually prevents the problem. If you, at the end of the day, are faced with a patient who is not really responding to your maximum dose of furosemide and acetazolamide and a thiazide, and there is not really low output, because if it's really low output problem, sometimes you can bail them out with vasodilators. If that is still the case, then there is room for ultrafiltration, but we tend to use it significantly less than about a decade ago with better guidance over diuretic therapy.
Thank you.
So, Professor Mullins, I would like to ask you as well, why don't you think acetazolamide is being used? I mean, the ADVAR study was impressive. You touched upon it during your talk, yeah.
Well, I can only get, in some countries it's not available intravenously. Because we've done the trial with the intravenous formularium, but there are several smaller trials now with the oral formularium in Spain, Poland, Brazil, Indonesia, and it also seems to work. So then you can give twice per day 250 milligrams orally. Yeah, people are still using a lot of thiazides, although the data, to be really honest, the data that we have, prospective randomized trials, is only Croatic, and it wasn't such a positive trial. So I think it's time that people move away from their stubborn behavior with only using furosemide and early on a thiazide and change it to something that we know that really works in a trial setting. So it's education, what we're doing here. It's also in guidelines. I hope they will change the guidelines next time and at least mention acetazolamide. But of course, the most important thing is getting the patient dry and putting him on optimal GDMT. You're not going to save lives with increasing only furosemide. But on the other hand, of course, if patients come in the hospital with a lot of volume overloads and they are already on GDMT, well, then you still need a judicious use of diuretic therapy. And that is actually what we're trying to learn to people how to do that.
Do you think, I mean, continuing on this point, do you think we should treat and modify the hemodynamics at an earlier stage, because it kind of comes in the end when nothing works and we wait a couple of days? Do you think we should be more upfront, be more careful about hemodynamics?
I think it's a good question, but most of the times it's not the cardiac output which is the problem. Even in HFpEF, the flow to the kidney is most of the time sufficient, but it's the efferent flow, the blood leaving the kidney, which is the problem. So having an elevated central venous pressure does more harm to the kidney than having a little bit, let's say normal cardiac output. So instead of giving more inotropes, which is still what people are doing, you should give them vasodilators. Especially in HFrEF patients with large ventricles, if you give vasodilatation, you reduce central venous pressure. That almost immediately makes your kidney more susceptible to diuretic therapy. If you give vasodilators to an advanced patient who is cold and wet, you also improve forward flow. And also improving central hemodynamics is important, but what's also important is measuring the intra-abdominal pressure. Many times these patients have ascites. This creates an elevated intra-abdominal pressure. The kidney is then then there's pressure on the kidney, external pressure. So in those cases, doing a paracentesis is also very helpful. So I completely agree that central hemodynamics, but also hemodynamics in the abdomen play a central role to improve the diuretic response.
Very briefly, but Wilfried, they don't tolerate vasodilators. They're in pre-shock or cardiogenic shock.
No, I don't agree, Lars. I really don't. I mean, I'm not talking about ventilators and HFpEF. I'm talking on a very exclusive group of patients who are cold and wet. So if you come in and you have a very high filling pressures and you have pretty low cardiac output, these patients respond really well to IV vasodilators like nitroprusside. I'm not talking about the cold and dry patients, but I'm talking about the cold and wet patients.
We have a question from the floor.
Fantastic talks and great session. How long should we give guideline-directed medical therapy to advanced heart failure patients? Once a patient has an LVAD, cardiac contractility is of course supported by a mechanical device. Is that patient actually still profiting from Entresto, from beta blockers? We know that blood pressure regulation is of course an issue, but we also know that kidney failure, taking that point from Dr. Mullen, is actually an indicator of worsening heart failure. Dr. Schorge?
It's a terrific question. I think that we optimally should then also try to get rid of what we do not need, but there's also the benefit of that therapy to the right ventricle, which we are not supporting, and the risk of arrhythmias, which sometimes interfere with the functionality of the LVAD. So probably we don't need all of them in the highest dose, but to keep those who are nephroprotective, to keep the beta blockers for the arrhythmic death, and to keep the ACE inhibitors or some kind of remodeling agent, I think there is some value in that. There's some data which supports that, not ultimately conclusive. But we typically, for the reasons you indicated, the problem with hypertension, we keep some degree, but not the full spectrum.
Wait, to be clear, after a patient receives an LVAD, you should continue GDMT, Benedict.
Yes, but they usually don't tolerate the full dose they had before.
Right. So that's the same as everything. You always give maximum tolerated GDMT. Period. Yeah. Don't complicate things. And it might also help with the not insignificant proportion that have recovery with LVAD.
Yeah, but it also depends on the indication. That's different for bridge to transplant and destination therapy. When you basically have an LVAD for destination therapy, you do know that nothing comes thereafter. Then you focus on quality of life. And when you have, for example, hypotension events, suction alarms, because then you need to have a pragmatic way, and that's usually decreasing GDMT a lot. It's not saying in the perfect way you have the four pillars still running in all the patients, but in some patients you need to make compromises, especially in DT patients.
One of the problems with left ventricular assist device and guideline-directed medical therapy is secondary mitral regurgitation, and currently we have 2 studies showing that stopping or even decreasing ACE inhibitor dose after left ventricular assist device, it's complicating clinical problem by allowing mitral regurgitation to act as a mediator of symptoms. There is no clear consensus how to do, but at this point I fully agree with Lars. We should continue and don't complicate the things as before of left ventricular assist device. Secondary mitral regurgitation after left ventricular assist device implanted, it's a major clinical problem.
That's true. But it's also a population these are few selected patients who have gone through a process pre-implant, which we really know well, and we closely monitor. We usually see those patients at least every 3 months, if not even earlier. So there's room to adapt the treatment, and they also face problems from the therapies, which is hypertension. So I think we should not just, that's the, I think, wrong population to say, just make it easy and continue. And I think that's the best population to have an individualized treatment plan, which is adapted to the patient.
Yes, Benedict, this is true. We need an individualized treatment plan for everyone. But the problem is in this way. We have guideline-directed medical therapy before left ventricular assist device. We're implanting left ventricular assist device. We're starting a long play with speed rotations and so on, trying to optimize perfusion and so on. And when we are forgetting ACE inhibition or decreasing the dose, this is a starting of nightmare for this type of the patients. If you have hypertension, your patient have diuretics, stop diuretics. But I think that although there is no any consensus, not guidelines recommendation, I think that the right option at the moment is to keep and not decrease ACE inhibition. And at this point, I fully agree with Lars.
And there is also recent data that came from the HARVEST trial that show that patients receiving ACE inhibitor at a lower rate of bleeding. They were all LVAD patients. As is
with LVAD, to clarify for the audience. Yeah. Right. So I think we need to take a step back. We're not going to discuss anymore how to treat patients who already have an LVAD. How many people here have treated a patient who has an LVAD? So 4. So the focus is instead the huge population, which is not in New York Heart 2, moderate HFrEF, doing well. We're not going to use the word stable because then people will get mad, but doing well, and who are not candidates for an LVAD or transplant, or who maybe but don't want one or don't have the possibility to get one. We're dealing with a huge population which is more or less advanced. So advanced chronic HFrEF is a huge dilemma. And these patients are, on the one hand, characterized by either not responding to GDMT or not tolerating GDMT. right? So what are the approaches for patients who are not responding to GDMT and not tolerating GDMT and who are not yet candidates for LVAD and transplant? They should be referred, of course, and everything should be early, of course. We always say we do everything too late. So rule number 1, earlier, and remember, we always do everything always too late. But let's be more specific. So one specific question is, do you think that it's justified to use interventions to increase tolerability? So do you think that you should use a potassium binder just to increase the use of MRAs? And do you think that you should use, for example, levosimendan just to repeatedly to maybe allow a patient to tolerate higher doses of beta blockers? Federica.
So according to potassium binders, the indication is there when you face recurrent hyperkalemia. What I face in my clinical practice in most cases is just temporary, and then you need to stop it. What is important is you restart it as soon as possible. And if patients again hyperkalemia, you can consider that. But I agree with you. This is something that we still don't really know. If they are not responders, then you have to evaluate something more. According to inotropes and the use of levosimendan intravenously in the outpatient setting, we have no data that show improvement in terms of outcomes. We don't do that in Switzerland. I know that many other centers, Oscar is also doing that in his clinic, but we are talking about a palliative care setting or just a strategy to stabilize patients waiting for heart transplantation if they are not LVAD candidate.
So that means that for patients who are progressing despite or not tolerating or not responding to GDMT, there is nothing until transplant, LVAD, or palliation. Is that right? Does anybody have any nuance to that statement? Can that statement be modified?
I would have a slight nuance.
Okay.
That palliative care is not only the part at the end. I think we totally need to refer those patients and evaluate them early, and we should not diminish that statement, because only if we see those patients early, we can make an individualized treatment plan and present them the options. Unfortunately, we still oftentimes see patients which come to the ICU in like a Intermax 1 or 2, who are then first presented, or their families are presented because they're not conscious. They're presented with the options of LVAD and transplant. If we discuss this earlier, then palliative care becomes a lifelong plan.
Sure. I agree that palliative care, everything should always be addressed earlier. I agree. But the question was not earlier or later. The question was before, whenever that may be. Does anybody have any suggestions about what to do in a patient with progressing HFrEF or advanced HFrEF that is not palliation, transplant, or LVAD?
I mean, it depends on the patient. There's a multitude of things you can do.
Let's hear it. Like what?
I mean, there is a potential valvular interventions in symptomatic patients.
But if they don't have, obviously, right. So if they have an indication for CRT, if they have an indication for MitraClip, of course. But if there's no indication for a specific intervention, then what?
And we heard some data yesterday about the DIGIT-HF trial, which
right. So vericiguat and
vericiguat.
Right.
That's not nothing. Right. That's something.
That's GDMT. It may not be 1A, and we don't know what's going to happen next year.
I wouldn't consider. I mean, I think calling vericiguat and digoxin GDMT, it's not our pillars of therapy. I guess
it's totally GDMT.
I guess it's in the guidelines. Sure.
Yeah, it's in the guidelines.
But it's not pillars of therapy, so it's thinking a little bit outside the box. And I do think that there is a role for device optimization with MitraClip and tricuspid clip in the right population. I think there's a disconnect between interventionalists and heart failure doctors. They've gone way beyond what we're aware of. We still think in the COAPT MITRA FR version of clinical trials, they've gone way beyond that for who they're doing in real world practice. So I think, exploring every opportunity, but I wouldn't say there's nothing.
No. I mean, obviously,
provocative, like.
No, what I'm saying is, obviously, if you have big MR, then there's an indication for MR. There's a lot of things. But what I'm saying is, if you have received maximum tolerated GDMT and GDDT, let's say, or you've received all interventions that are available, and you have a patient who either cannot get or doesn't want a transplant LVAD, so you have palliation. And is there anything else? Does anybody do something that is off-label? Does anybody in those patients use inotropes? I know that you do.
I mean, sometimes we use levosimendan as a palliative measure for if we see a good clinical response. I mean, it's not for prognostic purposes.
Yeah, I mean,
just
I've
for
sent
palliation.
people home on inotropes in one rare instance. Other programs do this routinely.
Exactly.
Well, especially
Very good.
in the US.
So many North American centers routinely use home milrinone drips. What else? Is there anything else? This is a big unmet need, clearly, but we need to get sort of think clinically oriented here. What would you actually do? Is there a role of, for example, evaluating diuretics, maybe reassessing additional diuretics, Wilfried, for example? Maybe we think they have maximum tolerated GDMT, but maybe we haven't looked carefully enough. Maybe there's something we can do.
I think it fits into what Benedict was saying, Lars. I mean, in those patients, you need to do a proper hemodynamic assessment, making sure that your patient is dry, having almost normal filling pressures. And most of the times that's not the case. And then there is, of course, more room for more aggressive decongestive therapy, and that saves you a lot. It improves prognosis a lot, although it's never been proven, of course, that if you decongest those patients and then they tolerate more GDMT or other additional therapies, that is, of course, of interest. The same Benedict was alluding to the fact of better monitoring. Those are patients that might be amenable for MEMS technology, where you can monitor congestion better. So I don't really have the patient who is really end of the line where there's absolutely nothing left. And if you have that patient, it's mostly because of comorbidities that you think, there's no use anymore of continuing. But only having advanced heart failure without any option in a younger patient, I mean, there's always the option of an LVAD or MCS-like therapies. I don't think, I mean, if the question is, should we bail out and say at a certain moment, now it's done? Unless you're really thinking palliative, there are many things that you can still investigate. Also, you have to do a proper assessment of the etiology. Are there things that you can overcome? There's many undiagnosed amyloids still there. There are other diseases there. There's screening of the family for genetic mutations to prevent heart failure. I mean, it never stops in our practice.
Yeah. Yeah, so I'm not saying that I have answers, but it's clear that this is a big problem, and it sounds like what we need to do is to look more carefully. Is there something we're missing? Could there be a significant MR that we're missing or have overlooked, or TR? Or could there be huge variability in weights and congestion that might be particularly appropriate for CardioMEMS, for example, despite its costs? Or could it be that a different diuretic regimen, most generally more aggressive, but also perhaps different, might be helpful? So it sounds like what to do is to look more carefully. Is that what the board would say?
Yes.
I think it always, yes, sure, but that's an ultimate answer to mainly all medical problems. So I think it all has to happen in the context with a given patient. They might not opt for LVAD now, but if they have a good consent about what the therapy is, they might opt for it later. So I still think that it starts there at eye level with the patient. And some of them don't want to go like through the whole diagnostic palette which we can offer, because they do not want to do an MRI every year and stuff like so. So it all depends a bit. I think it's not always about what we can do technically, but also what they want, and needs to be, I think, in advanced heart failure focused on quality of life as well. Because, for example, you're totally right. We rarely do this because of our healthcare system, but there are some patients coming for levosimendan infusions and then going ambulatory again. But some don't want that. They don't want to go to the hospital every 2 weeks. They rather have a slightly lower functional status. I think what we we can always do anything, but what we do needs to be discussed at eye level with the patient.
But I think we all can agree that there is a need for something bridging between these types of patients and when you give LVADs for a transplantation.
Yeah, that's true.
So, I mean, we need new drugs.
Yeah, it's interesting. If patients come to you, they most generally accept an LVAD. But if you screen and come to the patient that says, it looks like you would benefit from an LVAD, most say no.
Or they say no immediately, and then you spend time.
And then they come, yeah.
Exactly.
Yeah.
And also probably what we need in this setting is not only drugs to bridge this decision time, but also new, better devices with lower risk that can you implant with a lower Intermax class.
Right, that's a good question.
A greater Intermax class.
Yeah, so Ovidio, what do you, or anyone, so leaving what we can do today, what do you think is on the horizon? What's the next advance in this group? What will we be doing in 5 years? Is it novel drugs, novel devices, improved monitoring?
Lars, I think all of this, first of all, I'm coming back what palliative care is, and many people are confusing palliative care with end-of-life care, which is totally different. And this type of the patients, how you described before, should be including a palliative care program, so better called Advanced Heart Failure Therapies Program, to discuss, and Wilfried raised an important point, progression of comorbidities, because we are aware about heart failure progression, we are not aware, and maybe sometimes we are sending back the patients between specialties because we are so wise and taking care of left ventricular assist device, don't care about comorbidities, and making a nice ping pong with other specialties with our patients. But foreseeing progression of comorbidities is critically important. We have some drugs. I will mention istaroxime. Istaroxime, it's a new digoxin with action on SERCA, so improving both inotropy and relaxation. It's proven to be positive in terms of end diastolic pressure in Horizon 1 and 2 trials 10 years ago, and now in seismic B and C trials in patients with precardiogenic shock. We don't know if we can change levosimendan infusion, as shown in Lionheart with iterative istaroxime infusion in patients with precardiogenic shock or severe advanced heart failure, poorly tolerant or maybe intolerant of guideline-directed medical therapies. There are other new compounds addressing phospholamban pathway. There are 2 phase 2 clinical trials on the horizon. We will see what's happened. And beyond this new molecules, one of these istaroxime, which has at the moment 4 positive clinical trials, and positive in terms of clinical benefit in the exploratory analysis. I think that treating of comorbidities, it's crucially important in this type of the patients, because one legitimate question for this type of the patient, as Lars described before, how common are these patients? Because from acute heart failure registries, only 5 to 6% of these patients are progressing at 2 years to advanced heart failure. From chronic heart failure registries, only 2 to 3% of these patients are progressing to advanced heart failure. So first impression would be not so common to deserve a special attention, but actually these patients are accumulating. And in some type of services like university hospital, academic hospital, hospitals with advanced heart failure therapies, these patients are dominating the day-by-day landscape, and we need some solution for these type of patients. Levosimendan started very nice, but 2 negative clinical trials, completely unuseful, and with warning signals for weaning from ECMO. So maybe it's not the right way to proceed for these type of patients in ICU and ICCU. Dobutamine and milrinone, it's using as protocol in some hospitals in Europe and in Israel for this type of patients. Sometimes replacing beta blockers with ivabradine, we may see. Sometimes reducing diuretic dose in the hope to keeping ACE inhibition or ARNI in these patients. And I like very much first lecture saying this because we have several meta-analyses saying that SGLT2 inhibitors have no any benefits in patients with advanced NIHA class. But these patients are less than 1% of clinical trial population. This is similar with Paradigm, Deliver, and any other kind of trial. There is only one trial, live trial with ARNI, saying that in this type, specifically in this category of patients, ARNI have no any benefits. So I think we should reconsider our philosophy to keep as much as possible, as long as possible, guideline-directed medical therapy for these patients. And it's, at the end of the day, a matter of medical art. Because we don't have guidelines, we should reassess the patients, maybe at 2 hours, at 3 hours, at 30 minutes, because this is a job.
Now I'm curious, Lars, what do you think?
Right. So for the future, I look for novel drugs, novel devices, and novel strategies. And strategies are related to different aspects of monitoring. So hemodynamic monitoring, but also logistical types of strong HF, close contacts, frequent follow-up. So drugs, devices, and monitoring. And I do think we are in a new era where there are, Ovidio mentioned a few, some exciting drugs that are qualitatively and fundamentally different from the incremental steps we've been taking for a few years. The drugs that we use now, they do improve outcomes, but they don't improve contractility. I think in 5 years, there will be drugs that safely improve contractility.
That would be nice.
Dr. Jankashar, do you have any questions?
Yeah, I mean, it also depends on the etiology of heart failure. In this part of the world, we see quite a few rheumatics, rheumatic multivalvular heart disease with heart failure. And with atrial arrhythmias, they do very well with IV digoxin all the time. So which unfortunately doesn't find a mention in most of the guidelines. It may not improve, it may not have a mortality benefit, but then the patients do feel good. So we use this digoxin quite a lot in our practice, and the patients seem to do well. Any comments from the chair?
Did you say digoxin?
Yeah.
So digoxin does have, it's GDMT. It is in the guidelines. It doesn't have a 1A recommendation.
It's not. It's class 2 or class 2A or 2B.
Right.
But then if the etiology is rheumatic, it seems to work all the time.
Sure. So digoxin is helpful in all patients with heart failure, and especially in patients with rheumatic heart disease. Very good.
So any questions from the audience? In that case, I think we'll end this session. Thank you so much for participating. Thank you.